Welcome, everybody. Welcome. It is Thursday night. Big Dave's Healthy Happy Hour in the house. As folks are getting logged in here, let me just say welcome to y'all. Remember to use the chat in the Facebook, or if you're in YouTube, there's a comments section. You can type up comments, type up questions for the guests, and we'll do a little Q&A later on. Very excited tonight about tonight's guest. He is the man when it comes to low carb diets, for low carb therapies, for everything from diabetes, overweight, weight management, all kinds of things. And he's got so much knowledge to share, and he's just a totally cool guy. So you're gonna love tonight's episode. It's Dr. Brian Lenzkes is his name, and he's going to be joining us from beautiful San Diego. Before I bring him on, just a couple quick announcements. One thing, do keep an eye on the Facebook page. I'm going to be moving my blog to a new site, Substack, and we're going to try that out and see how it works. It's got all kinds of fun features. I'll be able to send out a newsletter to y'all, have it delivered right to your inbox, where it can get lost with all the other spam that you get. And so that's going to be a lot of fun. These podcasts will be able to post those up there. So just keep an eye out for that and the announcements for our next guests. Again, follow, like, do all the things to make sure you don't miss a thing. Oh, and the other thing I want to say is Happy Nurses Day. My good friend Paulino Hilai, hopefully you're watching tonight. Also, Aniela, Michelle McCann. I'm going to leave out some people, but thank you to all the nurses. I think it's safe to say that after this year that we've had, none of us would be here without nurses. So thank you all to the work that you do. All right. Before I bring him on, let me just say that even though he is a doctor, and a real doctor, not like Dr. Ben Bokikio, who's just got a PhD, he is not your doctor. So always consult with your doctor or nurse or shaman or whoever you're going to talk to before you take on any lifestyle or dietary changes. So nothing here is medical advice. That said, I am very happy to bring on and introduce Dr. Brian Lenzkes. Welcome, Dr. Brian.
Hey, Dave, thanks for having me. Thanks for everyone for listening. Hopefully I don't torture you too much in the next time we have together, but yeah, thanks for having me, man.
Not at all. Not at all. Thank you for being here. So I stumbled on you in the low carbosphere, I guess, through your podcast, the Low Carb MD podcast, and love what you do there. And you've now got a second podcast, and we'll talk about that one, Life's Best Medicine, also very cool. But you and I talked about a year ago, I guess, in preparation for my book, My Unremarkable Brain. Available now wherever books are sold. So folks get a copy. But such interesting stuff that I ended up putting it as the last chapter of my book. The final word is really I gave you, because I think what you're doing with your practice is so interesting, and I think it's going to change a lot of lives, not just in your practice, but it's going to change how medicine's done. So I want to make sure we talk about that. And but before we do, let's get to know you a little bit. A lot of folks from low carbers, but also folks from all over the country tuning in, coast to coast. And so I'm always interested in hearing origin stories. So let's take us back. What kind of kid were you? Were you the jock in high school? Were you the artist kid? Were you the band camp nerd? What made you go into medicine to begin with?
Yeah, it's kind of crazy. My story is kind of, it's funny. I was always overweight as a kid, grew up overweight. And I thought, I want to do something to help people at some point. I thought maybe I'll do physical therapy. I was trying to figure out what I want to do. Overweight, but never like majorly obese, but always overweight. I was on the heavier side and short. I'm 5'8" now. And I don't think I ever grew since fourth grade or something. I was waiting for that growth. I'm still waiting. Maybe someday I'll pick up a foot somewhere. But, in high school, I really started thinning out, played football, and I wrestled. Being smaller, I had to put on muscle mass and work out really hard. So I'd work out really hard, but then I realized, wrestling season. I wrestled at 160, like 168, and I played football at 205. So if I started losing weight too quick, my football coach, I played nose guard, defensive line in the middle. So I couldn't, I had to be fast and I had to be strong. And so when I started losing weight, my coaches would notice, like, get on the scale. Wait, why are you 180? What are you doing? Like, start eating again, that type of thing. So I was like, oh no.
Yeah.
So I would kill myself to get to wrestling season.
Wow.
And then I would gain weight again for football. So I would love football season because I eat whatever I want and try to bulk up. And then I would have to lose a bunch of weight and be in, that crazy stuff we do in wrestling. Anyone who wrestled or boxed, you're killing yourselves, spitting and running and going in the sauna, going in the jacuzzi, running, spitting, sweatsuits and all that crazy stuff because you're trying to lose water weight to get down to weight. And then my senior year at 178, and then all of a sudden, boom, started gaining weight, college, what do you do? Take a study break and have a pizza, all those kind of things. So I started gaining weight slowly. Then I go to med school. What do you do in med school? Let's take a study break. Let's go get a pizza, whatever. And then residencies, it exacerbated that problem. So I always thought, I must have messed up my metabolism in high school. So since then I can't cut weight. And I was just a struggle. And a lot and you realize, I'm in trouble. So, 15 years into practice, I'm gaining weight. I was 50 pounds heavier than I am now. I was doing the ADA's recommended diet, eating 6 small meals throughout the day, drinking green shakes in the morning, pre-diabetic. My 3-month sugar average was 5.9, which is in the pre-diabetic range. I see my sugars going up. I'm like 122. I was like, this is not good. And I'm doing everything right. So long story long, one of my patients came in and lost 40 pounds. I said, what the heck are you doing, man? Because I'm killing myself and I'm not losing any weight. And my wife would change her diet a little bit and lose tons of weight. I was like, how's that happen? And she was never heavy, but she would just lose it really quick. I'm like, how is it that I have some weird genetic predisposition to gain weight and I'm not very good at losing it?
Right.
So one of my patients lost 40 pounds. And I said, what the heck are you doing? He goes, you're not going to like it. I'm doing it's called the fast diet. And I go, what's that? He goes, 2 days a week I fast. I eat like 500 calories, no carbs. The rest of the week I eat what I want. And I said, so you eat what you want. You're having beer and pizza and cake and whatever. He goes, yeah, on the other days. But he says, I go, so let me understand this from a medical perspective, because we're all calories in, calories out. We know what works and what doesn't. We know the ADA's recommendation. We know what Weight Watchers says. So how's it work? So if you don't eat on Tuesday, you must eat twice as much on Wednesday. He goes, yeah, that's the weird thing. Is when I fast on Tuesday, I'm not that hungry the next day. It's weird. And so, and I didn't understand the concept. I go, how could you not eat and not be hungry? If I don't eat lunch, I'm starving. He goes, I don't know. It just happened. And then I started losing weight. Then he got so nervous because he was losing so much weight. He stopped doing it and started eating regular. And then his weight plateaued. So he thought, and I'm like, let's check you for cancer to make sure, or diabetes and all these other things, because we don't see weight loss for no reason, basically. And so I started researching online, weight loss, fasting. Who comes up? Of course, Jason Fung. So I was like, who's this nutty guy, right? So I started watching the video. And I remember sitting at my desk thinking, if this guy's right, I'm going to be so upset, because he's saying you don't have to eat Melba toast. And I'm eating rice crackers with a little bit of peanut butter on it for my lunch. And I'm having a little snack here and almonds and apples and oranges and, smoothies. And I'm gaining weight and my sugars are worse. I'm like, I'm going to be shooting insulin pretty soon. Wow. So then they interview Jason at the end of this. I'm thinking, what's he selling? What's he selling? The whole time. As soon as he says he's selling something, you have to go here and buy my book. Then I'm going to say this guy's nuts. And he said, the interviewer said, hey, if fasting's so great, how come no one's doing it? How come no one's talking about it? He said, because there's no money to be made, right? Basically, because it's education. You have to change what you're doing. But I started learning and reading about it, like, how can fasting work? And I started realizing, you drop your insulin level down. So I actually reached out to Jason Fung. And of all things, he emailed me back. He goes, hey, Brian, what do you want to know? And I started asking him a bunch of questions and learning. And so that he was a huge influence on me to get started down this pathway. Then I read Gary Taubes, and there's so many great names. So when you say I'm the expert, there's no way in heck I am. I've learned everything I've learned from that. And you've seen the trajectory on the podcast of saying, I like this. I love when you say, it's funny. Because Ben Bakikio is one of the smartest guys I know from a biochemistry standpoint, from a physiology standpoint. He knows it all. He knows all these crazy stuff. He'll just pull out and he knows it. Ben Bickman, the same thing. So when we had Ben Bickman from BYU on, who's one of the most decent, kind, brilliant people I know, he said, tell people I'm not really, because we were calling him Dr. Ben Bickman. He goes, I'm not a real doctor. I was like, I use your stuff every day. Ben Bakikio, both those two Bens, actually, whenever I give talks, I have both. People get confused. They don't know who's who, because I really respect them both. Mm-hmm. So it's not the MD degree. There's a lot of MDs that have no clue, and there's a lot of PhDs who are changing the world, and we have engineers coming in, changing medicine. So there's so many great people that we're all kind of working together to figure out how to help people.
Yeah. No, that's true. That's why it's so interesting being, part of what I tell in my book is just sort of this journey of learning, and just, the more you learn about, the more you want to know. And, you start just going down the rabbit hole. Those same names, Jason Fung, his book, The Obesity Code, it's incredible. That was the one that really Well, him and Gary Taubes, those two books really opened my eyes to this whole way of eating and this whole thing. But so much to unpack there. Let's jump back just a bit. And it's interesting. You talked about cutting weight for wrestling. I was a rower back in college, and in rowing we have a weight class too. There's heavyweights and lightweights. Now I'm 6'4", so even at my skinniest, I was skinny as a rail, and I was 180. So I was never going to make the 165 cutoff for lightweight unless I cut off a leg or something. But I remember that so vividly. The guys trying to cut weight before a race, worrying about it as we get into the season, like, oh boy, I got to make that 165. I'm a little high. All kinds of weird eating habits. Spitting, dipping the tobacco so they could spit. Buddy of mine, Cecil is his name. He went into, he didn't make weight, for this race, and everybody, all of his boatmen. Of course, in rowing, there's 8 other guys in the boat, right? So if you don't make weight, then these other 8 guys can't race, right? Like, what the hell are you doing?
Yeah, there's a lot of pressure. Yeah, you don't want to wait till the last second on that one for sure. Yeah.
Yeah. So he goes into the bathroom, comes back out, makes weight. They're like, "What did you do?" He's like, "I took off my underwear."
So, I've had people shave their head, shave their everything, and doing it. One guy was biting his lip, punching his nose to make his nose bleed just to get that last ounce or whatever off. It's ridiculous, crazy, right?
Yeah. It's just, and it's got to be kind of a breeding ground for eating disorders, I would imagine. And some serious stuff. That and then you mentioned fasting as well. And this is one question I wanted to get to with you is that you do hear some criticism about low carb restriction, that it's too restrictive, right? Or fasting, it's a disordered eating pattern, that sort of thing. You've got the clinical practice. Do you feel like that's a danger? Do you feel like that's something that you worry about with your patients?
Yeah, there's great. As a matter of fact, Tro Kalasian, who's on the podcast with me, and we've kind of dealt with this. There's different schools of thought, and I think part of it is knowing the patient in front of you. And I have this conversation a lot. I have some people say, yeah, twice a month I'll have pizza and I'll have cake and I'll do what I want, and I don't feel bad about it. I'm cool, and I don't go off the rails, and I'm good. So moderation only works for people who can moderate. So if I have a friend who's an alcoholic, I don't say, well, just have alcohol sometimes so you don't binge on it when you do drink. You say, don't drink if you can't control it. Other people have a drink every 3 months, and they tell their wife, look, I just have one drink and I'm not going to have more, and they're controlled. They haven't had major issues. And so then they can get away with having a drink here and there. So just because you struggle with alcohol doesn't mean everyone else in the world does also. And just because you struggle with carbohydrates doesn't mean everyone else in the world does also. So I think there's a lot of people who don't understand the physiology. Tro did a study showing that if you cut carbohydrates, you're less likely to binge, because people are binging on processed food and sugar and cake. And, those, no one says, I'm going to go eat broccoli till I throw up. So you have to understand the physiology of what's happening in that person. So there's a lot we've learned. I've learned a ton over time. And some people, it's a hard thing because, like you're saying, people who struggle with weight, a lot of people say like they're trying to do, in this whole physiology of high insulin level, because when your insulin's high, your stress hormones are high generally, and that makes you more likely to binge eat, and you're going to be more, if you're sleep deprived, all these big lifestyle stuff, it really makes a huge difference. And I've learned that more than anything. Like I know who's going to fail most of the time and who's going to succeed most of the time based on mindset, stress levels, what do you do for fun? What do you do for joy? How do you relieve stress? All these things. So, addiction. So addiction is such a hard topic. So most people, if they're going to do a time restricted eating and they're not disordered, or, obviously we always screen and talk to people about history of bulimia, history of anorexia. And so I've had patients with a history of both, and they're doing fantastic. Just saying, okay, let me moderate these things. Right. Yeah. You don't have to quit them totally. And I love David Wolf. There's some great Joan Iflin, Rob Sivas. They all come from an addiction standpoint. And my approach generally is, because people, and Dr. Unwin has talked about this also, all these great people, great minds, is some people will cry if you say, look, you can never have pizza the rest of your life. Like, okay, what do I want to live a life like that? So people say, forget it. I can't do it. I'm not even going to try it. But what we find is a lot of times people say, okay, look, just don't eat store-bought pizza. If your uncle makes pizza, or you go to the best Italian restaurant, have pizza. Big deal. So when you don't preclude that from ever being a possibility, and Dave Wolf and I kind of had a little bit of a difference of opinion, because he says, look, zero tolerance. And I go, it's kind of hard. If someone's loves a glass of wine here and there. And when you say zero, that's all they think about. And that's the argument against this kind of lifestyle. But if you say, okay, not today, maybe tomorrow, but not, and that's what David Wolf is saying. I love that. It's like, okay, I'm just not going to have candy today. Maybe I will tomorrow, but I'm not today. Yeah. But it's just like saying I'm going to climb the Mount Everest today, but if I can go 10 feet a day, I can do that probably. Right. Yeah. So I think it's that you don't run a marathon tomorrow, but you train for the marathon. So you don't just run a marathon. You say, oh, let me start with a 5K and see how I do. And then, so we see this natural progression. So when someone comes to me that's been struggling with obesity and weight gain, I don't say, hey, let's start fasting today, because they're insulin resistant and their insulin's too high and they're going to be miserable. And so all day they're miserable, they're starving. And then they go to fast food and eat French fries and Coke to make themselves feel, because they're starving. Their body wants to survive. So I think the more we start learning that patient, and I'll ask people. I have one lady today I interviewed, as a matter of fact, my patient for a long time. She's zero tolerance for alcohol. She goes, once I have one, I cannot stop. So do I tell that people just moderate it then and just have it sometimes? No, you say she knows herself. And I go, you know yourself. And that's great. And so other people say, if I have one, Rob Sivas, if I have one M&M, I'll eat 5 pounds. Right? So if you're that person, you have to know. So it's the person to realize, and we work together and say, how do we make it so it's something feasible? Like I got fat on chips and salsa and tortillas. I don't go to Mexican food very often. I can have my carne asada. I can have all that stuff. And at home, I'm not tempted by the chips because I don't have them there. Right. So it's just figuring out what your kryptonite is. Some people have a sweet tooth. Some people have, salty tooth. So I think it's just really figuring out that patient and what makes them tick and what their experience is with food, because food is ubiquitous, right? It's everywhere. And we use it when we celebrate, when someone dies, when we're sad, when we're happy, when we're this. And so it's hard if you have a problem with it to socially be socially acceptable. And, you don't want to stand down and go, no, I don't eat that. Right. So when I'm in Guatemala, do I have a tortilla? Yes. Because they hand make it and the person's showing me love and kindness. I don't say, oh, that's poison, I'm not eating it. It would be ridiculous. Right. But I don't do it every day either. Right.
Let's go. You mentioned insulin a couple of times, and I know that we have some folks who are longtime low carbers. I see Robin Dobbins here. Hey, Robin. Some folks who might be low carb curious, but kind of curious about how it works. Can you give us sort of the overview, the basic version of what low carb, why it works, and how insulin is a part of that whole thing?
Yeah, I think the big problem is the sad reality of medicine right now is no one checks an insulin level. So most people listening have never had it checked. And I have people all the time that I check it for the first time and it gives us a ton of information. So Ben Bickman, in his book that we were talking a little bit about before, he talks about insulin, high insulin level as a causal, not associated, but causally related to multiple diseases that we're treating with pills: hypertension, dementia, erectile dysfunction, go across the list, heart attacks, cancers, all these things are causally related to high insulin levels. So you go, okay, how come no one's checking that? If it's that bad, look at heart attack risk. I show slides that people go, look, the big one is high insulin levels. Diabetes it's decimating. And for me, being in practice as long as I did, I saw the devastation of diabetes. And that's a disease that's, people don't realize. When you get diagnosed, you get scared and worried, but a lot of people just say, well, just eat whatever you want and we'll give you more insulin. So Jason Fung was the first one to really get me thinking about it, because, to us doctors, diabetes is a problem of having too much sugar. So if your sugar is too high, insulin, for people who don't know, is your pancreas makes this hormone called insulin, right? And it goes out and it grabs sugar and it shoves it somewhere. So it can shove it in if you're a big Sean Baker, a big muscle person, shoves it in your muscle. No harm, no foul. It's never going to hurt you there. That's okay. That's glycogen stores. Then once your muscles start filling up, it says, okay, well, now where should I put it, guys? Okay, let's shove in the liver. Liver's like a backup battery. And I talk a lot about this fatty liver thing. And then, I'll put in the fat tissue, subcutaneous fat, the love handles. Love handles actually is very interesting. It doesn't increase your risk of cardiovascular disease. It decreases your risk. It is anti-thrombotic, anti-inflammatory. And we have tons of data on this. After 20 years of medicine, I never realized that until about 6 months ago when I started researching it, trying to figure out, is there a difference between fats? Why do some people lose weight fast and some people don't, right? Doing the same thing. So visceral fat is the bad one. Once you run out of subcutaneous fat, it starts going to visceral fat. So insulin's job is to keep sugars low. It does other things too. It tells the liver, okay, it's really saying, hey, there's a lot of energy in the system. Liver, don't kick any sugar into the system because we have enough. I'm going to go there and I'm going to start grabbing that sugar and shove it in places. So overnight, it lowers your, if say you tonight you have spaghetti and tiramisu, right, and a Coke. Your sugar's high. Insulin goes high to get rid of that. Insulin's high, and it's overnight is lowering it down, and shoving it places all night. By morning, your insulin starts going a little bit low, and then you eat cereal and toast and orange juice. Insulin goes high. So whenever your insulin is high, it's telling your body you have enough energy. Don't release energy from fat stores. Don't release it from the liver. We have enough here. We don't want more. So that is what insulin does, right? And insulin also, interestingly enough, acts at the level of the kidney and makes you retain sodium. So we've been telling everyone with high blood pressure, don't eat salt because it'll raise your blood pressure. Well, why don't you lower your insulin level down? Then you don't hold on the salt. Then you can eat more salt without getting heart failure. So we have data, and I have clinical experience with people with heart failure saying, oh, that swelling in my feet is gone. Right? I used to take 4 diuretics. Now I don't need it anymore. Why? Because their insulin level dropped. So insulin is a big problem. So with diabetes, we look and say, well, we'll just wait till the sugars go high and we'll treat them with insulin. Well, the studies, there was a big study called the Accord trial that we all said, okay, let's not control the sugars too tightly, because if you do, they get more cancer, more all-cause mortality, heart attacks, strokes, everything. So let's let the sugar run higher. Well, it wasn't the low sugar that was a problem, because otherwise all the people with low sugars would be dying with low sugars, right? The problem was that they were using insulin and other drugs to lower the sugar level. The more insulin you throw in the system, the more damage you have to the lining of the blood vessels, the heart, the brain, and all that. So if people are eating cookies and donuts all day and just shooting insulin, yes, your blood sugar can look great, but it's all being shoved into your tissues. Now you have amputations, you have blindness, you have kidney failure. All of these things are causally related to metabolic disease, which is the fatty liver. All these things are so diabetes doesn't just happen one day. The analogy Jason Fung talks about with insulin is this. If you came to me and say, okay, doc, look, I'm drinking 10 beers a night and I can't get drunk. What should I do? I said, well, drink 12, 14, 16, 20, 30, keep going up until you get drunk. Or do you say, and I have a perfect example I posted today. Or you could say, hey, you know what? Why don't you cut out alcohol for 2 or 3 weeks? Taper it down a little bit. Right. Then you go out with your friends, you have 1 beer and you feel it. You don't need to drink 30 anymore. And so once you get your body sensitive, I just posted today a patient. She came to me, her 3-month sugar average was 10.5, right? And she's on a drug that was costing her herself $562 a month, right? And it makes you pee out extra sugar. But on a low-carb diet, it's very dangerous to be on that med. So I said, we're going to stop that today. And she said, you're crazy. Are you kidding me? There's no way I can, like my doctor said, I'll never come up. I go, you will. With low-carb, you will. We'll watch your sugars. The first day she called me 5 times freaking out because her sugars bumped a little bit. Then the next day they came down. The next day they came down. So now after 3 months now, her 3-month sugar average went from 10.5 to 6.7. Wow. Off of meds. Wow. And you go, wow, it was lifestyle. Now she's exercising. Now she's taking care of it. So it makes you realize that high insulin level. It does a lot of other stuff. It makes you hungrier. It makes you fatigued. It makes you stressed. It makes you foggy mentally. So when you get that insulin level down, people feel better. And you say, okay, if you're feeling better and your sugars are better and your blood pressure is better and all your other stuff's getting better, okay, let's keep doing this. And I think that's what we have tons of experience with other docs out there doing great work, in psychiatry. We have, Dr. Georgia Eid talking about there's so many areas of medicine. Think, wow, this is crazy. Could our lifestyle really affect us that much? Yeah, it is. It's really, kind of can't be unseen in a way, right? I love, you mentioned Dr. Jason Fung. The quote that I remember from his book is, he says, I can make you fat, period. All I need to do is give you insulin. And that basically, if you inject a patient with insulin, they, which is the standard of care for somebody with diabetes, right? That they become fatter and fatter as time goes on, or gain more and more, fat. I want to talk about different types of fat, because that to me is pretty fascinating, pretty interesting. Before we do, folks, ask questions, put comments in the chat there. We'll get to your comments in just a moment and your questions for Dr. Brian here. But we're talking about hormones, and we're talking about how they sort of control fat storage, right? In fact, you did a talk, I guess it was at Low Carb USA, about visceral fat. And I heard it the day after I had heard an interview with, you mentioned him before, Lustig. Dr. Lustig was talking about, he says butt fat, gut fat, and liver fat, 3 types of fat, right? Butt fat is that subcutaneous, which you mentioned. The gut fat is the fat, belly fat kind of thing. And then the liver fat. So as a person who struggles with my own belly, what are some of the things to, number one, to be worried about with belly fat, and number two, what do I do about it? Yeah, I think that's the age old question. I don't think we have all the answers, but what I'm seeing clinically is I see some people, and there's some great Dr. O'Mara talking about Sean O'Mara was talking about this, and it really stuck in my brain. I thought this is kind of crazy, but he was saying, look, if you start losing visceral fat,
Mm-hmm.
even without exercise, you put on muscle mass. So I was like, that's
Really?
weird. Like, why would that be? You lose fat around your organs and you start putting on muscle mass.
Right.
Okay, that seems weird. So basically, I look back at my own experience, and like I was saying, I was struggling with my weight. My wife's always relatively thin. After Christmas and holidays and all that, you gain 15 pounds. You go, okay, that's it. We're gonna start eating 6 meals a day, and we're gonna do green shakes for breakfast every day, and we're gonna get rid of the meat, and we're gonna. And all of a sudden, I'm gaining weight, and she's losing weight. I'm like, how could this be? And I'm working out 5 or 6 days. I've never been lazy. I've always worked out, right? But I'm thinking, it must be the stress of my job. It must be something doing it. And I had a really stressful job at the time, which is why I'm doing what I'm doing now. And so I thought, this is crazy. How could she possibly be losing weight? She doesn't even work out. I'm thinking, this is crazy. And then we go places, and people look at her and go, oh my gosh, look, you lost so much weight. And you look great. And no one says anything to me. I'm like, gosh, dang it. I'm not losing weight like she is. And I'm going to work out harder then. And I'm going to eat more, whatever, right? And I'm eating a ton of carbs. But I didn't realize I was insulin resistant. She's not, right? So then it comes down to more calories. But you have to realize this is a hormonal problem. This is a hormonal problem. When your insulin's out of control, it's hard to lose weight. That's the determinant of gaining weight. So, a lot of people, and there's studies out there, and we could talk about it if we have time, but it's very intriguing. And I started realizing, So when I started my practice here, I have a guy who comes in, he's 320 pounds, diabetic. We measure visceral fat in my office. He has 13.3 liters of visceral fat. Okay. His wife is 158 pounds and has like 1.2 liters of visceral fat. So I told her, look, I'm just going to straight up and tell you, I don't want you to have unreasonable expectations. Your husband's going to lose a ton of weight. He's going to lose a ton of water weight. He's going to drop his insulin level down. He's diabetic, and we're going to get his sugars under control. And she was there just to support him, really. And she wasn't into low carb and keto. And so I go, okay, so don't get frustrated because he's going to lose a ton of weight. You're not. First week, they come back. She loses 4.8 pounds. He loses 0.6 pounds. And I'm looking at his 24-hour glucose meter. He's not cheating. He's doing everything right. And then next week, she loses 2.8 pounds. He loses 0.6 pounds. She loses 3 pounds. He loses 1 pound. And it was ridiculous. I'm thinking, this guy, man, is ridiculous. How can this be? And she's looking great, and he's not losing any weight. But he goes, Doc, I know it's weird. I only lost like 5 pounds, but my clothes are falling off me. My shirts, that you have that gap in the buttons, gone. He goes, my pants are loose, and my belt I'm tightening. And I was like, 5 pounds? You're wishful thinking. So we get his measurements. I'm like, holy cow, you lost 3 inches off your waist. How can that be? He didn't lose hardly any weight. So I started thinking about that. And I was thinking back to Dr. O'Mara and some of the stuff in my own experience. I thought, how can it be that you're doing everything right and you're not losing weight the way you should, but he's losing inches without losing weight, right? Because we're looking at the scale. So I started thinking about it. I said, how does this make sense? Why on God's earth would you ever have a situation where you're going to benefit from being more fat with no muscle? Like, he's not putting muscle mass on and things. So, and he had not a lot of muscle mass for his size. So I started thinking about a bear, and I thought, well, a bear, what do? They hibernate for 6 months. So how do you hibernate for 6 months? You get as fat as you can and you lose muscle. So I was like, maybe the visceral fat is either harder to burn. It has to be, because he has more fat to burn, but he's not burning it. Or, it's either that or there's some hormonal thing going on that just doesn't make sense. So I started researching. I started just doing research and took a week and just every night said, what, visceral fat, subcutaneous, there's a difference. They act different biochemically, hormonally, hormone response, all these kind of things. So I started thinking, the bear wants to get as fat as it can, get rid of muscle. Why? Because it wants to hibernate for 6 months. If it's full of muscle like Sean Baker and has no visceral fat, the thing's going to sleep for a day and wake up because it's going to run out of energy. It can't survive that way. So you want to decrease your amount. So what happens is, as we get fatter, our visceral tissue is very immune to breaking down, right? So when it's hard to break down, you have to do a lot more. It's like oak. You have to burn a lot of oak. Someone with subcutaneous fat, they just burn kindling. That's why when people say they lose a bunch of weight quickly, if I see someone's visceral fat is really high, it's going to take a long time to burn through that. And as they're burning through that, they're putting muscle mass on. So the weight doesn't show on the scale. So they go, forget it. I tried for 3 weeks. It didn't work. I'm done. Keto doesn't work. But the reality is they're putting muscle mass on. They're getting metabolically healthy. And those same people, I'm seeing their insulin level drops. I'm seeing their A1C drop. I'm seeing everything get better. They feel better. Their energy is better. Everything's better, but the scale doesn't show. So I think this is a huge area that we haven't talked about. Is like, okay, if you put on muscle and you lose fat, you're metabolically healthier. Our goal ultimately is metabolic health, right? So that's why there's a different schools of thought. These big muscle guys, like you hear, like in the low carb, Lane Norton, he was just on our podcast. Him and Tro just go at it, and I go, you guys are looking at different populations. If I have if I have Sean Baker, I could load that guy with carbs. I guarantee you he's not going to gain weight for a long time. Right. But if I have 65-year-old diabetic who has no muscle mass, I can't carb load that person. I can't put them on green shakes and think they're going to get better. And that's why my wife could get better, but I couldn't. There's a difference in the type of fat and how you store it, and whether your body's good at getting to that fat store or not. Right. And high insulin level blocks you from getting to your fat store. So most diabetics, obese diabetics, are going to have very high insulin. So what do we have to attack first? Lowering the insulin level so you can get to your own fat stores. Right. That's kind of the point.
Yeah. It's so interesting, the individuality. And I think that, you mentioned it a couple of times, the way you work with different patients differently. It's actually, that's a great transition in a way to thinking about how, we talked about sort of standard of care, the way the medicine usually works with diabetes and stuff, and how you're looking at things differently. And one thing that came up in that story you just told is just the curiosity. Like, what doctor would spend a week researching, reading papers and things just for this one patient that comes along? That's what I love about what you're doing. Your talk about physician burnout that I saw, maybe it was about a year ago now, right? Year and a half ago, maybe. Really eye-opening. I mean, we think of doctors as sort of being the best and the brightest, and they've got it all together, and they know what they're doing. And they're these superhumans to the white lab coat effect, But some of the really shocking statistics that you gave about suicide rates and depression rates and drug abuse rates and things like that, and how that sort of opened your eyes to a new way of practice, right?
Yeah, absolutely. And look at it. I was one of those docs. I always love being a doctor. I love it. I love helping people. I love that hope in someone's eyes. Hey, I can help you. This is the end of the world. We're going to plan this thing. Let's do better. And I think the problem has become, doctors are the best and the brightest theoretically, right? So we worked hard in school. We're type A. We may not have as many friends because we worked hard and we're studying all the time when everyone else is going to the beach, So there's a ton of sacrifice. So I feel for docs, and I know docs in some healthcare systems where they have 6 to 8 minutes per patient, 6 or 8 minutes, right? So their wife left them, and they have all these problems. Like, okay, here's your medicine. We'll see you next time. Good luck, right? Because you don't have time to say, hey, let's talk about metabolic disease. So that's why doctors are, the reason I was starting to get burned out is every single patient that comes before me, I want to help them. I want to do the best. And once I started realizing Jason Fung was right, and I was seeing clinically, within 6 months, I had 11 patients come off insulin. In 15 years before that, 0. Never happened. Because like you said, if I want to make you fat, what do? You get diabetes. I put you on insulin. You take insulin, you come back and you gain 30 pounds. I go, what's wrong with you? I told you to watch your diet. I did, doctor. I did what you told me, the ADA diet, and I gained weight. Dr. Unwin has a great story on our podcast talking about that, because he had a patient who lost weight, and she said she did the exact opposite of what he told her, and she started losing weight, and her sugars normalized. She came off insulin. She did it herself because she had common knowledge. She was upset at
him, right?
Yeah, she looked back and he said, what are you talking about? I gave you the ADA diet. This is the standard of care for diabetes. She goes, I was getting worse. I was getting fatter. And I was getting more diabetes. And I was taking more medicine. Then I'd start eating eggs for breakfast and I'd come off insulin. So I think once you see it and you experience, you think, wow, this is kind of crazy. Like, how can this possibly be? So for me, I don't really care what the expert opinion is. I care about my patient in front of me, right? Yeah. So, but when you see that, and I have 15 minutes per patient, if that, I would see someone that I know is going to get diabetes based on their insulin level, based on their 3-month sugar average, based on the trajectory of change, based on their lifestyle. And what I would be right in the middle of trying to help someone, it would be, doctor, there's 3 people waiting. Doctor, you can't. Doctor, hurry, doctor. And I was like, you know what? And then I started realizing, I started looking at the system. I go, how come my other partners aren't burning out as much as I am? And it was really because they were just saying, okay, your blood pressure's high, here's a pill. Your sugar's high, here's a pill. That's the standard of care. That's
prescription medicine, right?
It's prescription medicine. You don't say, hey, your wife left you and you're having, I just had a guy today, his wife left him, he's having heartburn. I was like, well, you're going through a stressful time, drinking too much, you're taking anti-inflammatories for your neck pain because you're stressed. Let's make some changes and see if we don't need to have tons of medicines, right? Let's be on medicine short term, but let's try to make some changes. Let's try exercising. Let's try doing other stuff. So I think when you start realizing that if you have 6 minutes, you don't have time, and that it's building up and building up. So I would always say, hey, put this patient who's going to get diabetes, or they just got diagnosed with diabetes, put them before lunch and I'll work through lunch. But then guess what? When I work through lunch helping that patient, I don't see my wife because I have to do all my callbacks at the end of the day. So I'm there for 3 or 4 hours at the end of the day. So I was working at least 14-hour days generally, right? Wow. Stressed, working hard. So I'm thinking, I'm gaining weight. I'm not feeling great. I'm working all the time. I'm trying to save my patients. 80% of them don't really care. They go, just give me a pill and don't tell me about all this other stuff. Yeah. So I realized there's a problem, and then there's an inherent problem in the system because, and I had a discussion with one of the head guys at one of the HMOs, and I said, hey, look, you know how much money I'm saving you guys? You know how much sacrifice I'm doing? Because my patients are not going to go on dialysis. They're not going to get out. Because I don't want to see that. As a doctor, you don't want to see your patients get their leg amputated.
No, you're trying to help people. Yeah.
And you don't want to be, any doctor out there knows you're treating ulcers from diabetes. You're treating blindness from diabetes, depression, anxiety, stress. All these things we're treating is like, oh my gosh, if we can just get like Ben Bickman says, Dr. Ben Bickman says, hey, lower the insulin, all these other things get better. And I start seeing all these other things. People say, well, my diabetes is under control, but you know what's weird? I'm not depressed anymore. Oh my gosh, my anxiety's gone. I feel like I'm enjoying life. You're like, wow, that is the cure to physician burnout. But for each of those patients, I had to see 30 patients. And then I realized our podcast was reaching more people than I could in my exam room. I was more effective doing that because people would educate that were drawn to that and wanted to know, like, yeah, I want to get off my meds. But other people say, well, it's covered by insurance anyway, so just give me more meds, keep adding meds. But you're going to run out sooner or later. Then you're on insulin. Then you're injecting. Then it's a pathway. And when you say I could reverse this like a country song backwards, this is fun now because people are coming and go, do you see my weight, doctor? Look at that. I lost 8 pounds. Look at this. My sugars are better. Look at my blood pressure. And you go, wow, this is fun now because I'm taking people off meds. Now we're kind of pioneers now, taking people off of medicines.
Right.
You don't need all the medicine if I'm giving you sugar to get rid of, medicine to get rid of the sugar, then get rid of the sugar. You don't need the medicine anymore. Right. So Dr. Unwin's patient said, well, if I don't eat toast, cereal, orange juice, and soda for breakfast, I don't need to shoot insulin for breakfast. I could wait till later. And then she said, well, if I eat something healthy at lunch. So you start realizing, holy cow, we're just treating, right, both ways. Yeah, we're treating either the excess of carbohydrates or we're taking carbohydrates so we don't get low blood sugar from taking the medicine. It's like, okay, why don't we get rid of both of them at the same time and live happier lives,
Yeah. No, that's exactly it. And I think that's why I think it's so innovative what you're doing. I mean, you use the I think I quoted you in my book using the AAA analogy, it's like the auto club, like, you're preventing problems as they come up so that instead of just kicking it down the road and having bigger problems later on, you get a flat tire, you call AAA and then come out and fix it rather than drive around on it. And then all of a sudden your axle is broken. Right.
Yeah, exactly. And the other analogy along those lines with the cars is that if I don't want the mechanic who's the best at changing my engine. I want the mechanic who says, hey, you know what? Your engine oil's low. Not wait. Oh, you blew up your engine. Okay, let's change your engine. Now we can do. I don't want to get a coronary bypass or my leg amputated. And then they go, oh, now we can treat that really good. It's like, hey, how about if we prevent that in the first place, doctor? Wouldn't that be a better use of your time and my time and my life, right? Because it's not all about the money. If you look at Medicare, what's their budget going to? Obesity and diabetes related complications, really high insulin complications. So why don't we fix that problem and look at that rather than saying, okay, let's just give everyone orange juice and then shoot them with insulin. It just doesn't make sense when you look at it from a patient suffering perspective and financial perspective. But people are coming around. I think more and more people are starting to understand that, wow, these guys are really they're not just making this stuff up. Because at first I thought, and it was true, a lot of my partners and friends around thought I was nuts because they're like, this guy's telling people like they can come off insulin. They can't do that. And I thought that too before.
No one ever heard of that, right? Yeah.
It's crazy. Like once you're on insulin, no one comes off insulin. It was never happening. I mean, even if they lost weight, they wouldn't come off insulin. So when you see it once, I was like, wow, they don't need insulin. This is crazy. And then the next person, when it keeps happening, go, okay, maybe it's not just blind luck that this is happening. They change their lifestyle and they get better and they come off their meds and they're happier. I was like, love this because I love seeing patients and I love like seeing that lab this morning and that 3-month sugar. I know the implication of having a 3-month sugar of 10.7 versus 6.7, drastic decrease of risk of all these complications. So I'm like, I'm happy. I don't want to see it, the other way, if your sugars are going higher every time I see you and we're battling, trying to bring it down and we're trying without really addressing the underlying changes. That's where we got messed up. And this is the sad part about it is we gave bad advice on diet. So doctors say, well, no one listens to us. They're not listening. They're just eating what they want, and they're not following the guidelines. Well, they were following the guidelines because I was following the guidelines. So I had the advantage of being overweight and saying, look, I was pretty much with myself most of the time. And I could tell you, I was not eating cake and ice cream and all this stuff. I was eating exactly what I was supposed to, and I'm gaining weight. Yeah. So these doctors who've been overweight, like Tro and a lot of people that are out there practice, they've experienced the other side of it and go, I was doing what they said. Yeah. I'm smart enough. These guys are not, the misconception that obese people are just lazy and gluttons. It's not true. There's a lot of brilliant people, brilliant scientists, but they just can't lose because they're not doing the right thing. And once they figure it out, they go, this is like all the time patients go like, I feel guilty. This is so easy. And I was like, how come no one told me this before? They're not sacrificing. They're not getting eating disorders. They're saying, look, I feel great. I'm able to work out now. When your insulin's high, you feel fatigued and tired. You can't work out because when you work out, you can't get to your fat stores and you feel miserable. But once you get metabolically healthy, it's like a light switch for people. And that's why I love it. That's the cure to physician burnout, having patients get healthier and not sicker.
Right. No, that's perfect. That's perfect. I love, who is it? Case for Keto, Gary Taubes, again, his latest one, right? Mm-hmm. And he talks a lot about that and how, a lot of the people who are in the low carb community are people who have gone through it themselves. That, if you're a person who doesn't gain weight easily, it's easy for you to make it a moral issue. Oh, you're just being lazy. You're just being a glutton. Right.
But just do what I do. We're all like that.
Right.
If you quit smoking, do it the way I did it. It worked for me. So it has to work for everyone else in the world.
Yeah.
Right?
Yeah. And he says, no, overweight people are not just skinny people who eat too much. They have a different hormonal milieu, and so it's biology, not morality, is what he says. And I love that, because in our culture, it's always this moral sort of, gluttony and sloth and all that stuff hanging over it. And you got to kind of first get away from all that and forgive all that and just say, look, this is a biological process. Let's use biology to fix it,
Yeah, and it's not only biological, it's psychological. There's so many factors involved, right? Because when people are stressed and you don't feel good, you're going to if you're depressed and anxious, you're going to use more drugs. It's just the way it is, right? Yeah. People are happy and everything's going their way. They don't need to drink all night. And, you get someone stressed out and tense. So like Jason said, I can make you fat with insulin and sugar. Guess what? We can make you fat with stressing the heck out of you and make your life miserable. We can take away your sleep. We can make you miserable at home. We can make you fight with everyone, and you're going to be in trouble. I see it all the time, and I'm telling you, there's truth to that, right? Yeah. So you go, where do you find your peace? Like, can you take a breath? We have data. I just read a study because it's all hocus pocus, but you look at meditation, 10 minutes a day, prolonged survival, decreased insulin level, better sugars. You take a diabetic and you make them stressed and sleep deprived. Guess what? You get sleep deprived. Guess what? You get more stress. You get more stress. You get more sleep deprived. Now you're in that cycle. A lot of people, don't sleep. Why? Because they're stressed and they're tense and they got to pay bills and they're shooting insulin. They're all these things are happening. So the problem with the diet studies, with that everyone quotes, a lot of them are poorly done studies. First of all, second of all, they put people in the hospital, lock them up, and go, okay, you're going to eat 500 calories of this or 500 calories of that. Well, if anyone eats 500 calories of gummy bears, are going to lose weight. Is it sustainable? Is the question. Right. When you get in real life, right, and like you say, regular life, all the stressors, all the problems, and that's so relevant today. I mean, with COVID, people working from home, people doing all the disruption of our lives. I mean, have you seen a lot? And by the way, I like how you talk about using a continuous glucose monitor, which is a little device. And for folks who don't know, you stick it on your arm and it'll tell you your blood sugar 24 hours a day, right? So you talked about clinically, you can see when people are more stressed. Do you see that on the continuous glucose monitor? Absolutely, yeah. Stress, all those things play a role, right? So to think one thing's in a vacuum is incorrect. And the argument, and it's controversial for sure, calories in, calories out. Well, we have studies that show if you block certain hormones and you work out the same amount as someone else, you don't lose weight. If you have a ton of visceral fat and you work out the same as someone else. So people who say, well, I hardly eat anything and I'm exercising all the time and I don't lose weight, it's probably true. They're probably not lying to you, right? They could be eating in the closet now, but the continuous glucose monitor takes that out of the equation, because I could see if you're eating carbs. I could see if you eat cookies or donuts, you get stressed out. It's there. But also, if you work out, we'll give you the same sugar spike, because once you're fat adapted, you release sugar from your store. So that's what I learned having it on. I was like, okay, if I'm working out, my sugar was 148 from 80 or 90 to 148 with a hard workout. Why? Because my body's releasing fat stores and sugar, so I can burn it. And then if I don't burn it, I just put it back where it came from. No big deal. So it's not that spike was the problem, right? So I had dietitians tell me, oh my gosh, look at you. What are you eating at night? And I was like, that was when I worked out fasted. I didn't eat anything that day and it spiked. So should I have carb loaded that 148? Do you want me to get to 200? Why should I have carb loaded that? And you have, people out there like Zach Bitter running 100 miles fasted, on keto diet. It's like, how's he do it? He weighs 142 pounds or something, right? He's skinny as well because he's tapping into his fat store. So it can be done. I think there's so much misperception. The CGM, continuous glucose monitor, is golden, because people realize, and it's not only Big Brother. Part of it's Big Brother. So I have people that are staying with me. They're done. They're doing great. Everything's fine. I go, fire me. You don't need me anymore. You got this. You know this. And they go, no, I need the accountability, because I know you're going to look at the CGM. I know I'm going to follow up with you in 2 weeks. So The other problem with medicine that I knew was a problem, and we all know it's a problem, is because we're so busy. We have I've been corrected by Dr. Horvitz that I would say we have an undersupply of doctors, and he said no, we have an oversupply of sick patients. Right? You think about that for a minute. That's the truth. Is we have so many sick people that I can't see that my diabetic patient. I can't see you every week. Your insurance isn't going to pay for it, first of all, and I can't physically do that, and you can't physically do that. So
you get 6 minutes once a year, and the person's walking by. Okay, yeah, great. And
because I can
where's
change
the follow up? Where's the accountability and all that?
Yeah, and that's what we learned. There's so many great people out there that I've learned from. You realize we're basing lifetime treatment sometimes on one lab number, right? You have a high LDL one time, statin drug, that's it. Instead of saying, why is it high? Let's look at that. Were you fasting? Were you not fasting? Were you stressed? So I think sometimes you have to look, and if I'm seeing someone more frequent, when we're doing Tro Collation, who really taught me a lot, who's my partner on Low Carb MD podcast with Jason Fung, say, hey, you need frequent follow-up. Because when I see people every week, fantastic. When I see them once a month, they fall off the wagon, right? If I see them once every 3 months, good luck. If I see a diabetic in October, I'm not gonna see him again until January based on the recommendations, right? Yeah. That means that you put Thanksgiving and Christmas between the next time I see you and New Year's Day, they could be in the hospital on major life support by then, right? Because left to your own, but if they know every day I can see their continuous glucose monitor, because that's why I tell people, like, man, just think for an alcoholic to have a continuous alcohol monitor on them, how powerful that is. Because as soon as they take a drink, their buddy's gonna call me, hey, what's going on, man? Right? Oh man, I was depressed. Hey, I'll come over. Let's talk. Right. So that's what we can do now is say, hey, your sugar spiked yesterday and today again. What's going on? Oh my gosh, here's what happened. My brother-in-law is here. Okay, that's it. I'm bad. So instead of letting them be off track for 3 months, it's 2 days. No harm, no foul. We can get you back on track. Right. But once you gain 30 pounds back and you're miserable, you say, forget it. I don't want to do this anymore. Right.
Yeah, exactly. And that's, by the way, folks want to find out more about you and your practice, Dr. Brian, it's low-carb MD San Diego, right? .com.
Yeah, you got it.
And your newest podcast, Life's Best Medicine, talking about stress and all these other factors, meditation, spirituality. Tell us a little bit about what inspired you to make this new podcast. I love it. I think it's really, really cool, and you have such great guests on there. But where did that come from?
Yeah, no, I love it. I realized when we were doing Low Carb MD, a lot of people would say when they were really down, when their sugars were incredibly high, they would lean on faith, and they would talk about what they would do and how they got their life back, how they dealt with stress, how they dealt with the stress that was making them overeat. And I started realizing, gosh darn it, and I'm a Christian. So I was like, I don't want to sabotage people or have a lost leader where people say, I want to talk about low carb. Now he's talking about religious stuff or faith or like how he deals with life, right? Okay. And I would get bad, people would say nasty stuff on Twitter sometimes, like, why do you talk about that? Just talk about low carb. Well, I realized that it's life in general. And I felt a calling to do this. Say, hey, look, I'm looking around as a doctor. I have to look at all cause mortality. I have to look at the whole picture. I can't just look at COVID. I can't just look at diabetes because, I don't say, well, at least he died of cancer. At least it wasn't COVID, right? I don't look at it that way. I look at the patient and go, look, what is the most likely thing to kill this patient, right? If you're 85 years old, you're going to have a different mortality than someone who's 21 years old, right? And so you start looking at the suicide rate. You start looking at the hopelessness. I talk to people every day, and a lot of the general population doesn't understand, but I have people like suicidal because they just lost their business. They put their whole life savings into, right? Their kids can't go to school. They can't go travel. They can't do this stuff they used to do. They've gained 20 pounds. Their sugars are out of control. They feel terrible. They can't go get a colonoscopy and all these other things that no one talks about the effect. And I said, well, one time on Twitter, I said, hey guys, don't lose hope. Keep the faith. Don't lose the hope. Things are going to get better. And I got attacked for 3 days for saying that. They go, how dare you talk about faith? And I said, faith, if someone says the F word, no one bats an eye. But if I say faith, like to help someone get through the hard time, don't give up. Because for me, hell is the absence of faith, right? I mean, of hope. When you lose all hope, that's when you jump off the bridge mid-span, right? So I think those kind of things, you think, gosh, I want to give someone some hope. When I see someone who's diabetic and say, we can make you better, we can help you, we can do this together, and you see that hope in their eyes and that they go, let's do this thing, we're all in. So that's why I did the podcast. And I talked to people from different faiths. Like if I've had a Muslim friend of mine on, Hindu, Buddhist, whatever, but really saying, what do you do when a good friend of mine today, we released one, his son got severe brain damage during birth and his wife almost died. And he said, he's sitting there in the room thinking, I'm going to lose my wife, my best friend, and they're very close, and my son on the same day. going from the utmost of joy. And so what do you do at that point? How did you deal with it? How do you not? So answering questions like that, because look, you can't prove faith, but you say, look, here's my story. It helped me. Maybe it helps you. Maybe you don't want to know about that, right? So I think it's just opening up the realm of saying, okay, look, let me plead my case. Let me tell my life experience. And then you can say this guy's crazy or not, or life experiences, I think speaks a lot. So all these people, and everyone has a great story. That's why the guests are great, because everyone has a story of how they deal with adversity. If you're losing your house right now, Keto Mojo people, their house burned down right when they're starting their business. Like, how'd you guys deal with that?
Yeah.
Right.
Yeah.
All this kind of stuff. So I love it. It's great. I love it.
Yeah. It's a brilliant concept, because we always stay in your lane kind of thing. Like you say, you only talk about this and don't talk about this other part of your life, and I'm guilty of it myself, but faith is such a big part of life, and just runs through. It's this current that runs through our day-to-day life, and to not talk about it is kind of weird in its own way, right?
Yeah, and I think if for me, it's like I deal with life and death. So when people are dying, they'll go, "Hey, doc, I'm thinking about it. I've had friends die. I've had family members die," and say, "What matters?" So really, I wanted the podcast to be like, "What really matters?" I've never been to a funeral where they go, "Oh my gosh, Tom had the best car in the neighborhood. His house was cool." And they go, "Man, I was depressed one day and Tom came and helped me. He helped me move when I needed it. He did those kind of things where you realize, man, it's so much about relationship and caring about people." And right now, more than ever, I see people separated. You don't see people's faces. As a sidelight along these lines, one of my patients she runs a nursing home. And I was asking her about how did that affect you with COVID. She goes, "We had a ton of COVID related deaths, but we had no cases of COVID." Meaning all these people died of loneliness and sadness, and their family couldn't come see them. And people just gave up on life, and they were dying left and right because they had no social contact. They had no bingo. They had nothing. They're sitting in their room watching the news saying they're all going to die. And when you lose hope, that's what I think is the most tragic thing, is to take someone's hope away. So if it's false hope with faith, okay, cool. If you believe, but if it helps you get through the day, if you think, putting a beanbag on, having a beanbag in your house makes you live longer and be happier, cool. I don't care, right? If you're better and it's a placebo effect, whatever it might be, as long as my patient's getting better, heck, But I know a lot of people who lean on faith and helping people and being kind, and that's what it's about. It's really realizing what really matters.
Yeah. So powerful. Do you have time for some questions?
Oh, absolutely. Yeah.
Let me jump into some of these. Sprocket Roswell, I think that's a nom de plume, but he says he's been staying away from sugar and carbs. It's funny, he used to have a sweet tooth before bed. Now he has a salty tooth when he gets home from work. Is that something that you often see? Yeah,
that's really common, and that's an interesting thing you bring up, because some people will have a sweet tooth, right? And it turns out a lot of times, believe it or not, if you're running low blood pressure, things like that, so if you drop your insulin level down, like people who go low carb and keto, what they do is they drop their insulin level down. So what happens? Your blood pressure starts going down. Your body says, "Uh-oh, we need to raise the blood pressure back up." So you could eat carbohydrates, raise your insulin, that makes you well in the salt, or you could eat salt. So sometimes people eat salt because their body's craving it because they drop their insulin level down. So that's actually a good sign, and a lot of people will switch that way. And you go, okay, is it emotional? Is it just I'm watching TV and I'm bored? There's so many reasons we eat at night, I mean, sometimes you're just like, I'm hungry and I don't know why. And maybe you just ate, but you want something sweet or you want something salty. But yeah, that's very common, so that's we hear that a lot. And sometimes people eat salt, their sugar craving goes away, right? So it's pretty cool.
Yeah, that's awesome. That's awesome. Yeah, and another one of those, you mentioned it before, that salt has sort of been demonized for way too long. What about Powie asks, is there such a good thing as good carb, vegetables, fruit, and bad carb? So is that a true distinction or?
Yeah, no, I would say the dose is the poison. If you're a 400-pound diabetic and your sugar's 400, there's no such thing as a good carbohydrate for you, right? If you're in the ocean drowning, there's no good thing of salt water. You have enough salt water around you. So your body doesn't really differentiate. Of course, there's a difference in your insulin response. So if someone's metabolically healthy and they're going to have, sweet potatoes, it's going to be a lot different response than having French fries. Potato chips are going to have a different response than another as a more complex carb, because it's going to release the sugar slowly. Your body panics on the quick release of sugar. So I got obese doing Slurpees because I go, it's non-fat. I'll have a Slurpee. Kids, we're going to go for a hike. We're going to have a Slurpee afterwards. So I burn my sugar and then I put it back on, right? Because it's non-fat. And we were all sold all these different products that, we all know what they are, that they said, oh, it's not fat. You can eat as much as you want. And we all got fat eating that. And, that's well documented. So yeah, absolutely. There is a difference between, for instance, having an orange and drinking orange juice. It's a huge amount of difference in sugar and how fast your body has to get rid of it. If you take yourself a big sugar load, you have to spike your insulin. We don't want insulin spikes. We want our sugars to be as flat as possible. So
right.
Yes, there is a
And
distinction.
the fiber plays a part, right? That's where that whole idea
Absolutely.
of net carbs comes in, because net carbs is the formula where you take the total carbs and you subtract the fiber, and that helps because the fiber helps to level out the big blood sugar spike like you talked about, right?
Absolutely. And just along those lines, one thing that's interesting, Ben Bikikio, the workout guy, has a guy that works out with him that really triggered my brain. He's a 27-year-old fit guy. Mm-hmm. And he has tons of muscle, six-pack abs, and I'm working out with him. He's a beast. And Ben goes, ask him what he eats. And I thought he was carnivore. And I asked, what do you do? I'm vegan. I'm like, come on, man. He goes, vegan. How do you get muscle mass? Are you taking steroids? We had a great discussion, but he feels good on that diet, and he eats a ton of carbs. He eats a ton of fruit smoothies and stuff like that. Yeah. He's fit and healthy. Why? He works out 3 hours a day. His carbs go to his muscles. Who cares?
Right.
If you're fat and you do that, it's going to go to your fat stores. I do care. If you're diabetic, I do care. But if you're not, if you're metabolically healthy, it changes everything. So that's why it's not just a radical one size fits all. You go, that's why Lane Norton, he goes, my guys eat Pop-Tarts and they're fine. Yeah, they're 6'5" and they have, tons of muscle. It just goes to their, and they're burning it off when they work out for 3 hours lifting weights. My accountant who sits at his desk all day doesn't have the same luxury.
Right. Good point. Sprockets, other questions similar about bell peppers. Any fruit, vegetable that you please, something like a banana will completely ruin the day or the week. And I guess you kind of answered this already about, sort of.
I think you can definitely be fanatical, right? So if if your sugar's 400, then you want to cut as much carbs as you can. If you're healthy and fit and you're doing great, like I tell people all the time, liberalize your carbs. Liberalize them. You're good. Like you want to go have bell peppers? Like seriously? Like that. So you can get a ridiculous extreme where you get fanatical. Yeah. And fanaticism never benefits anyone. It really doesn't, because people say, forget it. If I can never have a bell pepper, I'm not doing it. If I can't have a piece of bread once a year, you think that's going to have, you think about it, smoking's terrible. But if someone has one cigar every 2 years, do you think it's going to kill them? Probably not. I mean, they'd have to have really bad luck. But if they have 2 cigarettes, cigars every day, and they're, so you start looking at it's the dose makes the poison. As long as you're not filling up your entire liver store and your fat stores and you're oversupplied, then you're cool. If you're working out and exercising, you can get away with way more carbs. Like I just said, the guy with the green shakes, I would gain tons of weight doing that because I'm not metabolically as healthy as this kid is. He's 27, but in 10 years, that may catch up with him when he's working at a desk job and he has 3 kids and his wife says you can't work out 3 hours a day, right? Yeah. So I think you have to start adjusting based on how metabolically healthy you are, because there are definitely people who can get away with more carbs. It's not that the carbs are the devil; it's the oversupply when you're spiking your insulin to have to force it into the train. It's like a storage unit. If you have tons of storage unit and you buy more stuff, who cares? But once your storage units fill up, now you're in trouble. You have to hire a bunch of people to start packing stuff away and pushing it in there. That's insulin.
Yeah, that's a good analogy. I like that. Let's get a couple more if you don't mind. Kathy asks, is the insulin test different than getting a glucose test or an A1C?
Yeah, absolutely. And that's why it's important to get the insulin is looking at the insulin itself. The A1C is looking at your 3-month sugar average, the A1C. The sugar level is what it is that day. Your sugar can change if you're stressed, if you're tense, but that's like the weather today. It doesn't tell me what the climate is all the time. It's just if it rains today, doesn't mean it rains every day. So you can have high sugars for other reasons, but the 3-month sugar average really tells us, okay, what has your average sugar been over this time? How much sugar fluxes are you having? Yeah. Now I look at the insulin level compared to the A1C generally. If your 3-month sugar average is really high and your insulin is really low, that makes me nervous, because you should be having a high insulin to try to get rid of that extra sugar. Right. Or if your A1C is normal, and I see this all the time, and they say, you're healthy. As an example, I have a guy who's 300 something pounds, comes to me and doctor says he's healthy. His cholesterol, triglycerides, everything, he's got a ton of fat on him. I was like, maybe he is. Let me see. I get his insulin back. It's 65. It should be less than 5. At 65, he's a total train wreck because you cannot sustain that. That's like if you're spinning on the treadmill, I know you can't run forever. I don't have to be that smart to say you cannot keep your maximum velocity. Ben Bikikio will tell you that. Yeah. And so, so looking at those in unison and saying, okay, if my insulin's high, this should be, we look at ratios and try to figure out, like, why is that happening? Because some people are just very insulin sensitive. They have a low insulin, low A1C. I feel really good about that. They're fine. Yeah. But the vice versa is not good. So that's why clinically we have to look at that and go, what's your insulin? Because I can see people, I've had several people, I said, you'll have diabetes within 6 months based on your numbers if you don't change what you're doing. One guy changed, one guy doesn't, one gets diabetes, one doesn't. So it's one of those things that's so preventable. And Ben Bickman, has graphs showing 10 years. For 10 years, your insulin goes higher and higher and higher until you get diabetes. 10 years, we have a warning. So when someone just gets diabetes, you don't just wake up with diabetes, type 2 diabetes in a day. Type 1, you can have an autoimmune problem and it can happen anytime.
Yeah. Excellent. How about intermittent fasting to help prevent dementia? This is an interesting question.
Yeah, you can Google it. You can Google type 3 diabetes, and that's dementia, Alzheimer's dementia. And I have people that really have a lot of mental fog. They're confused, and when they're eating a ton of carbs and their insulin's really high. And so there is definitely, there's a lot of science going on with this, and I love it. Georgia E talks about this with Diagnosis Diet. She has some great information on that. Nick Norwitz, he has a predisposition to Alzheimer's disease, so he's looking at how do I best keep myself from getting Alzheimer's disease or dementia. And a lot of us are seeing insulin, and there's a lot of talk about, and this is something I'm actually researching at the time, is looking at insulin resistance in the brain. When you have insulin resistance in the brain, it makes you more hungry, more stressed, more angry, all these things. So you say, okay, how do I fix that problem? I'm looking like, how do you fix that problem? And I think it's just being low carb, putting on muscle, lowering your overall insulin level, and then your brain becomes more sensitive to insulin. I'm sure there's scientists out there who may have, more recommendations on what we can do, but absolutely keeping your insulin. Dementia is one of those that Ben Bickman has shown is causally related to high insulin levels across the board. I mean, I don't know of any non-infectious disease, and maybe not even infectious disease that's associated with high insulin level, high sugar, that's not associated with those things. So, that's one of those things you look at and go, okay, if that's the canon, that's a big problem. Let's fix that problem and not throw drugs at everything else. And so dementia, once it happens, is very difficult, right? And that's the situation. There's some great products out now that can help seniors. Instead of eating really terrible stuff they're giving people, let's try to cut the sugars out and see what happens. If we can keep them from getting dementia, we could delay it by 6 months or a year or 2 years or 5 years or forever. I'll take that. Right. Yeah. I think that's the data we're seeing. Yeah. Great question, though.
Great stuff. And Ed also asks, why don't doctors do insulin tests regularly if this is such an important hormone?
They don't know. They don't look at that. They just look at the sugar and they say, what's your sugar? They don't realize, so most have not. I didn't know. I practiced for 15 years before I even thought about insulin. Or Jason Fung said something. And I started looking at it. I'm like, what's insulin? Like, we never talked about, we talk about sugars being too high. We never talked about insulin deficiency, too much insulin. We know diabetes. If you have type 1, you need insulin. So no one checks it. And people don't know what to do with the data. And that's the problem is, there's a major HMO. As a matter of fact, today, I think it was my 130th patient from them that I've consulted with because they refuse to check an insulin level. People are diabetic. They have all these problems. They say, well, because some people just don't make enough insulin. If you're Asian or Indian descent, you may not make enough insulin. And if you don't make enough insulin, what do you have to do? Make yourself as sensitive to that little bit of insulin as you can. How do you do that? Put on muscle mass, get rid of visceral fat, all those things. If you're obese, what do you have to do? Make yourself as insulin sensitive as you can, right? So you put on muscle mass, get rid of visceral fat. That's why it's not all about calories in and calories out. It's really about how you distribute that and how your body reacts. So it's really critical to know that. So, and there's places online you can look it up. There's labs, you can order your own labs if your doctor refuses. It's incredible. I know doctors that will refuse to order any extra labs because they don't know what to do with it. First of all, they get this number and they go, I don't know what to do with it. Right. Coronary calcium's in the same thing. They don't know what to do with the information. And plus, a lot of the HMO plans and mostly HMO plans, they'll dock the doctor if they order too many tests. So they go, oh, you keep ordering this. I got in trouble. Not in trouble, but people question, like, why are you checking insulin? Because me checking insulin is saving you a ton of money down the road if I can educate the patient. Because if I tell you your insulin's high, you're in trouble, even though they don't know they're in trouble, they'll listen.
Right.
If they say everything's healthy and fine, keep doing what you're doing, they're going to keep doing what they're doing, and you're going to give them diabetes. They're going to end up in diabetes because they're not being educated. So that's the point. People just aren't educated. So I'm hoping that we can all get out there and educate. That's why we did low carb MD, so we could educate. You can listen to other docs, and we have tons of docs who are joining us now and understanding. They go, oh wow, now I'm checking insulin. Holy cow, I didn't know. And because Jason Fung passed that information to me, we could pass it on to other people.
Yeah. It's powerful stuff. It's great work that you guys are doing. At both podcasts, that was one of the questions. I don't think I wrote down the other one, but Low Carb MD is the one, and Life's Best Medicine is the other podcast. Just spreading the word and getting it out there and trying to help this movement go forward, right? What's next? Yeah. What's next for Dr. Brian?
Well, I'm doing some fun stuff right now. I'm loving it. I'm having a lot of fun. I'm consulting with the fruit company in Vacaville. And I'm talking to 23 of their employees. The owner cares about the health of tons of diabetes in the Latino community. They're decimated, right? I do a lot of volunteer in Guatemala, a lot volunteer work overseas, and you see the decimation because of cultural ideas and stuff, and they think soda gives them energy. And so anyways, just being able to educate them. 23 people. I was on the big screen. I did it via Zoom, and it was so much fun. So I'm hoping we could do more things like that, where we get employers who say, okay, we care about our employees. And I was making the point to them. I said, look, your employers are great people. Your employers are great because they care about you enough. They're footing the bill to get the labs, to get the continuous glucose, all these things to help you and educate you and get you right. But also they're smart because they know you're gonna be better employees. You're gonna call in sick less often. You're not gonna be having to get your diabetes, ulcers taken care of. If they have healthier employees, they're gonna keep you, and you're not gonna be in the hospital, and they won't have to hire and train new people. They're smart too. But it's building that rapport in that community where people can do it together and say, let's see if we can change it. Because doing it on your own is hard. So that's the other thing we're doing. We're building communities. We're doing Zoom meetings with our patients so that, and people talk about, but I'll get a group of my patients who are doing metabolic, trying to reverse their diabetes or obesity. And we say, hey, we're going to meet on Friday. We're all going to go for a walk for 2 hours and talk about life and go through go on a hike together. And people say, well, I'm struggling with this. How do you? So they get time with me, but also they have time with each other. Say, oh, I used to have that problem. Here's what I do. Because everyone, and I think this is important for people listening, is we all think we're the only ones struggling. Right. Yeah. And so I have people struggling and I try to give them a platform, and then they don't say anything. And the next day they say, oh my gosh, I'm the only one who doesn't have my act together. I'm like, 4 other people have said the same thing to me today. Say it and let's talk about it. So we throw something out there. Does anyone else struggle with cravings at night? Yeah, me too. Oh my gosh, me too. And they realize they're not the only one. So if you think you're the only one struggling with a problem, alcohol or whatever it is, and depression, anxiety, seek help on those things. Like a lot of us are struggling. That's devastating to me that depression, anxiety, stress, it makes you eat bad stuff because you don't care anymore. So look, have self-compassion when you say, look, I want to take care of myself. It's worth it for me not to eat bad stuff when I feel bad about myself. And, there's so much entangled in all this stuff, but we could definitely as a society do a lot better. Yeah.
No, well said. So well said. A lot of wisdom there. The last several people have asked, do you take virtual patients? Do you do remote consultation for people who are not in San Diego? I don't know the answer to that. Do you?
Yeah, I do, but mostly I'm doing, I generally want people to come see me and I want to spend time with them. I want to check their visceral fat. I want to get their labs done and stuff like that. So there's a lot of great people around, the country who are doing this kind of medicine. So generally I'm sticking with California. I think I'm going to get licensed in Arizona and Nevada, possibly in the near future, just because, I work a lot with Ben Bikikio. And so I think, having us working together is really a huge deal. So yeah, I think I'm going to look into licensing, but right now you have to establish care with me here in San Diego, which is a nice, a lot of people come in and meet with me once, and then we can monitor them for 16 weeks on their own via Zoom and all those kind of things, to get labs remotely and all that. So, I like to listen to your heart and lungs and, just make sure we're all on the same page and everything, and make sure it's a good fit and it's a good option for you. So and I do direct primary care, which is also a different part of it, with less monitoring and just, being a regular doc, and trying to focus on low carb. But, some people just aren't interested, but we still do all the other, stuff and, have accessibility and all that. Sure.
Yeah. I'll throw in one answer to that for folks that are interested in working with a doctor or a practitioner on low carb. lowcarbusa.com. Doug and Pam, great people, have done a great job putting it, and they've got a provider directory where you can put in your zip code and just see who in your area does low carb. That's how I found my own general practitioner.
And that doctor also, there's a lot of great resources, but I think Doug and Pam are great resources. You reach out to them and say, hey, I'm in this town, and hopefully Low Carb MD, we start having more doctors who are opening up. So we know different people in different areas. And so it's great. It's really great to see it because, a lot of people are helping each other, and it's great. There's, just great people in this area of medicine, and it's, underserved. And again, the people who are dying of COVID are the ones who are metabolically sick of every disease process. So you say, look, let's try to prevent that. I want to live a long life and be happy and play with my grandkids and not have sore back and knees and sit on the bench while everyone else is playing. So I think it's those kind of things where you look at this lifestyle stuff and what we can actually do without throwing a bunch of drugs on you, because all those drugs have side effects.
Yeah, very true. Every drug has a side effect, right? Well, thank you so much for being here tonight. I really appreciate you making the time. I think a lot of folks have gotten a lot of great information out here. Hang on one second. I'll say goodbye to you off the air. But thanks again, Doc.
Hey, thanks for the invite. I greatly appreciate it. Thanks for everyone listening. Thanks for the great questions. Those were fantastic. I really appreciate that and appreciate the time. So it's nice.
Okay, well, thanks everybody for tuning in. Have a great night. Have a great weekend, and keep tuned in. Keep like the thing and follow the thing and share it if you could. Share it with all your friends. Get the word out with all this great stuff going on here. Have a good night. Be well. Stay healthy, everybody.